I know it's quick and obviously not a real life scenario for 4 minutes, but it just gets you a bit of a taste of the type of scenario. So it's just making sure you get all your questions in, but also with what we're now going to do. Anyone's got some differentials? I haven't actually written anything down, but you guys do the work. Differentials.
Peptic ulcer?
Peptic ulcer, yeah, why that one?
Why?
No, I said I like that one.
Oh, sorry. Why? Gastric
Why
ulcer?
though? Gastric cancer?
Esophageal.
Yeah. Reasons for gastric cancer?
Anemia and melena could be feeding.
Yeah.
Cancer, weight loss.
Yeah. Risk factor,
And
smoker, alcohol. Yeah, hasn't actually had any problems with his swallowing, but could also be esophageal malignancy. Yeah, anything else? Those seem probably the most likely.
Esophagitis?
Yeah. I don't think he hasn't actually been vomiting or anything, but what's he taking? What's classic? What's he taking?
NSAIDs.
He's taking those NSAIDs. Yeah, okay, so what investigations we
Could
can
you
do?
say gore?
Second?
Gore.
Yeah, GORD as well, definitely. They all, those group diagnoses tend to come as a group differential essentially. So what investigations might you do?
Do you repeat the full blood count?
Yeah, I think that's probably sensible. Just thinking from an F1 perspective on MAU, depends. If someone's come to MAU that may have come from GP or they may have come from A&E, so if it's taken earlier on in the day, you may say, okay, we'll repeat it in the morning. But you might want to do some, if his HB is that low, look at the trend and also think, is he symptomatic with his anemia? So you're going to ask shortness of breath, is he pale on examination and stuff like that? And you might want to group and save him because he may well not have been grouped and saved. But this could well be chronic. You could be looking at this guy's HB could have gone down from 11 to 8 over a year, which doesn't mean that you wouldn't have to transfuse or anything. So sort of you may get a hit of results in sort of a chronological fashion. If he's dropped it really acutely, then you're obviously thinking, well, is this also pouring out or is it something else? That's fine. Anything else?
Can you do the H. pylori antigen blood test?
Yeah, I think that'd be worth doing. I'm just sort of thinking from this person's being admitted to hospital, or query should they be admitted to hospital?
Do an OGD?
Yes, fantastic. So yeah, like I said, in the OSCE, do your blood tests, then say, right, further, whether it's imaging or scoping, so I'll request an OGD. Yeah, exactly. And that's more likely to find what you're after. Really, it was probably a peptic ulcer, but all those are possibilities, definitely. So that's just a few basic facts on peptic ulcer. Important ones for an F1 and for your OSCE and revision and things. Complications from a peptic ulcer: perforation, GI bleed. Be prepared that some highly paid actor is going to pretend to have a GI bleed or pretend to have a perforation, and be prepared to deal with it acutely. Okay? You'll have drilled into the ABCDE, and we're going on to something like that. Okay, so standard treatment for peptic ulcer is PPI, but realistically, in an OSCE, they may give you may have a short history that's a bit more obvious, then you're asked to explain an OGD. And obviously with all your explanation stations, just like fourth year, you want to try and set them out into what do they understand from it initially. Okay, any concerns, then start your explanation. Risks, make sure we've got capacity. Same for any explanation station, but you might be asked to explain an OGD to someone as well as their history. Okay. So you know what's coming now. I think if you guys were here a couple of weeks ago, I think there was someone else did a bit on GI bleed. So really common thing for OSCEs, and it's important as an F1. Had one on the nights at the weekend. It gets your heart rate going, definitely. Causes. There's a few just important ones that you just need to be able to bang off straight away. Varices, yeah. Not the most common, but potentially the most serious. Yeah. Mild advice, yeah.
Peptic ulcer.
Peptic ulcer, yeah.
Or any ulcer. Any ulcer.
Any ulcer, yeah. So varices you can get in your esophagus and you can get gastric varices. Who's going to have varices? Alcoholics, yeah. Why? Yeah, exactly. Causing backflow. Okay. Varices, I think, off the top of my head, I think about 7%. It's around that sort of figure. It's below 10%. But your ulcer disease is your big one. Okay. So are they going to bleed or they're going to perf? Okay. Other more rare ones, and one I've had previously, someone's been pouring out from the back of their nose, not out the front, from an NG tube, and has then been vomiting that back up. So always just try and think, in a situation you get the notes and just after you've assessed them go, right, is this person alcoholic, have they got liver disease? When you examine them, look for signs of liver disease, not expecting a full abdo exam because that's not needed in this situation, but that will give you a clue if it's varices, because if it's varices, your management will be the same but with some additions. Okay, so who's brave to have a go at this one? We'll involve you all, but someone take it on. So you've got your bleed. Are we on nights? Yeah, we're on nights.
Elderly cardiology and gastro.
No. That's what we do. Okay, so this isn't quite what I had, but I've had similar. Right, here's your bleed. It's bleeping. Answer it. Who's going to answer? Don't worry. I'm not going to be harsh. Who's answering? You just have to do the phone bit. We're all going to do the next bit.
Yeah, I'll do it.
Good stuff. Right. Okay. Phone me back. I don't know if to be Yorkshire or Philip. All right, Doctor.
Hello, I'm your poor uncle.
Oh, thank God, Doctor.
Can you tell me what's going on, please?
Oh my God, Gary's pouring blood out. He's vomiting everywhere.
Okay, ready?
He's get here quickly.
Where are you?
The gastro ward.
Okay, and who's Gary?
It's Gary, the alcoholic.
Okay, what's he in with?
He's got acute liver failure.
Okay.
But he's looking awful. He's had 2. I think. Marge, what's that? He's vomited again. He's vomited
Okay,
again
so he's
everywhere.
been vomiting large amounts of
Just
blood.
this black, like
Black.
you know
Coffee
yeah,
ground?
I think coffee ground. Yeah, that's what
Yeah.
I thought you doctors called it. Yeah.
Okay, and when did this start?
Like 5 minutes ago. I think you really.
Okay,
Yeah,
is he looking really unwell? Yeah, I'll be there soon. I just want
Do you want me to
more
do it in the
information.
meantime?
Yeah, can you take a full set of obs for me, please?
Yeah, no worries. I'll get the healthcare to do that.
Okay. Can you find out for me if he's got IV access?
Yeah, I don't think he has. I don't think he's got
Okay.
anything. I think they've just been doing his aside. He's got some ascites coming on as well.
Okay. And
Cool, coming?
Yeah,
Awesome.
coming.
I'll see you in a bit.
Okay,
Cheers.
thanks.
Right, good stuff. If you identify that it's a emergency early on, you did exactly the right things. You got the patient information. You got where you needed to go. Okay, you got that this guy maybe say how much blood, but I said he's vomited blood everywhere. So essentially, that is now an emergency, upper GI bleed until you know otherwise. Okay. So things you might say down the line are, you did exactly that. Do some obs straight away. You find out if there's access. That's more for you preparing when you go. But you'd be thinking that on the way anyway. You probably want to say, just say, right, sit them up. Have the suction ready. Can you have a couple of cannulas ready if he hasn't got any access? If he's not choking, get him some high flow oxygen. I'm coming straight away, and just leg it, because ultimately this is an emergency. Okay. Really good. Practice those. You might get that in the OSCE, because Lee's OSCE directs you towards being an F1. Being an F1 is being on call, answering the bleep, deciding, do I need to go there straight away? Can I review them later? Okay.
So do you think if it sounds more like an emergency, then don't be so strict on the whole S-bar thing that they
Yeah, fair enough. I mean, in the OSCE, maybe they'll get you to do a less urgent scenario that gets you to do the S-bar structure. Okay. But personally, in real life, you'd get your core essentials, tell them to get stuff ready for you, and go. Because ultimately, because it's an acute emergency, you need to get the nurses aren't going to put the cameras in. The nurses probably, I don't know, they may not do the suction. But yeah, always practice it in the S-bar routine. On my first set of on-calls, everything I forgot to get, on my first on-call, I forgot to get the patient's name, where they were on like the third bleep I've got. So the S-bar always makes sure that you get all the key information. Even if the nurse on the other end of the phone is panicking, get what you want, get the information you want. Okay, so likelihood in an OSCE practical station, you might have that scenario written, or the examiner might say, right, you've just been called to the ward to see Gary, he's vomited blood everywhere. What would you do? So just write down what your management would be, try and do it systematically, and then we'll go through it together. Something that might not change your management, but direct you a bit. The obs that Andrew asked for, you guys tachycardic at about 120, BP's 90 over 50, his tachypneic high 20s, and he's got his SATs low 90s. Okay. So that information is waiting for you because you asked for the obs. So that's there on the chart when you get there. Yeah. And always carry your F1 handbook, just in case you forget. We're getting on. Doesn't have to be in detail, just what you actually do in real life. Okay, so won't pick on anyone, but what would we start with? You go in the room, this guy's, he's sat up on that type of bed. What would you do? Say it? Yeah, okay. What would you do there?
So you kind of assess his airway whether it's
Yeah, he's vomiting blood. He's just vomited blood, gurgling a bit. What do you do?
So you make sure that he kind of has access. So turn him maybe into a cold
Yeah.
position or something, get some oxygen on him, high
Yeah.
flow.
Yeah, exactly. I told you the sats were low, so you know, could have aspirated a bit on the vomit, either that or second.
Get some suction, get a nurse to get
Yeah, absolutely.
suction going.
Get a nurse to attach the suction, do it yourself. Obviously, the risk of trauma of suction, you know, the risk of that, the benefit of actually getting blood out of there far outweighs the risk of causing any trauma. Yeah, okay. So you've suctioned some blood back up. He's sounding a bit better. He's on some high flow. So we'll say high flow, non-rebreathe. Fine. Next, what would you do next?
Large ball cannulating because you took the
Yeah. I mean, technically, if you're doing the ABCD, you have a quick listen. Again, like I said, he might have aspirated on some of this, on some of the hematemesis. Yeah, let's just say breath sounds normal. Next.
Get some access.
Yeah, specifically.
2 large bulk
Yeah, so try and get 2 greens in, if possible.
Take blood whilst you're doing it, breathing second plus
Good, excellent. Yeah, okay. What bloods are you going to do when you take cannula?
cross match,
Yeah.
full blood canal, using these LTs, but
Clotting?
yeah,
Yeah,
clotting.
clotting. So I'm sure you're written it down. Yeah, excellent. So obviously thinking of F1, you've got to think practically as well, and that shows in the OSCE. Well, you've been on the wards and you're actually thinking you know what you're doing. So cross match, how many units?
All.
Depends how big a bleed, but if this guy doesn't, if you've assessed him, someone said he's an alcoholic, he's got some chronic liver failure signs, you think it might be varices, they're not going to stop really necessarily. So they always say 6, maybe 8 units, but this is, that's a proper GI bleed. Okay, so you take the cross match and you actually call transfusion in real life and say, look, I'm sending this down. Got a guy who's got an acute GI bleed, can you cross match? You might need to use own egg blood, but obviously what's going to be more accessible? So you've got your cannula in, what you're going to put in, he's hypotensive. Yeah, so haven't got a fluid chart, but what would you write? Yeah, what do you want, doctor? None of that on normal. Yeah, it's fine. 500, how much?
500 mils.
Yeah, excellent. Okay, and then you put up another bag quickly as well, especially if he's hypotensive. Okay, let's have a quick look. Rattle on.
Does every ward have O negative? Or is that just an
It will be in a blood bank. It won't actually be on the ward itself, but there's a fridge where the blood comes up to for the wards to pick it up from, and certain people on the ward will have access to own egg blood. Okay, own egg blood. If this guy continues to pour out and you can't maintain his BP with fluid challenges. Okay.
Unlikely you don't have to use a negative.
Yeah, I mean, it's not. In the few months I've used
It's
it.
mainly obstetric, please.
If
Yeah.
you're a major hemorrhage, so you've got a major hemorrhage for a major hemorrhage defense.
Yeah. So, with your GI bleed management, is the patient shocked? Okay. This guy we've just dealt with, tachycardic, hypertensive, hypoxic. This guy's shocked. Okay. So you've said everything. Obviously, when you've got your clotting, you might need to correct that. Catheterise is actually important once you've stabilised them. Obviously, renal, urine output is such a good measure of renal perfusion. And I think it's OGD in less than 12 hours actually now, but you may need to speak to the on-call endoscopist as well. Less intense if the patient isn't shocked. So if you want to fill in a piece of paper on the back of your sheet. And just a quick question, if it was a variceal bleed in your OSCE, what would you give? Something additional apart from stabilising?
So can you give it as an F1?
Vasopressin.
Yeah, it's terlipressin, but essentially, it's vasoconstrictors. That's all it is now. think, is it 2 milligrams a hand?
Sorry, I've never given it.
Yeah, I haven't given it either, but might be useful to know. I think you can give 2 milligrams IM, but you'd speak to your senior before you went giving that. But it's a good thing to say in the OSCE, consider maybe giving it. So again, in the OSCE, you might be expected to fill in the blood transfusion form. Okay, make sure you can fill in that properly. So in the acute situation, you don't know blood type, you don't know antibodies, so just write it down. And it was you who took the blood. Make sure you always tick, double identify. This patient might not be able to consent if he's acutely unwell. Have you guys come across Rockall Score?
Yeah.
Heard of it? Yeah. Another score called Glasgow-Blatchford. That's the one we use at Pinfields, and that sort of basically that's up to 40%. Sorry, the ones who rebleed, I think 40% then go on to sort of really high mortality rate. Rockall Score helps you predict, your risk of mortality from GI bleed. Okay, you don't have to know this off by heart. Okay, for OSCE, some people learn it off by heart. I could kind of half remember it. It's more just being aware of what the main risks are for it to be a high risk GI bleed. Okay. Right, just going to rattle through jaundice. This is all written paper, so we'll skip that out. So again, if you take a history from a jaundice patient, try and split it up in your head, okay? And if you want to do a differential. So, are they breaking down loads of hemoglobin to give loads of unconjugated, or is it intrahepatic? Things like hepatitis. So in your history for the jaundice, okay, it may seem like cholangitis, but screen for hepatitis risk factors shows you thinking. Of course, alcohol, PBC, PSC you may have come across very rarely, extremely rarely. Again, that's more just for the written. Does anyone come across or know about PBC and PSC? Anyone done a gastrofilm this year? No? Okay. It's not that important, but basically, for written stuff, PSC is associated with ulcerative colitis. Basically causes it's inflammation essentially of PSC is intra and extralobular hepatic ducts. PBC is just your intralobular ducts. Okay. Hemochromatosis is holding on to your iron, Wilson's holding on to your copper. Post-hepatic choledocolithiasis is just basically, in fact, does anyone know the actual definition of that? Anyone know? It's a posh, formal way to say. Yeah, so it's an obstructive stone. Yeah, exactly. More serious things, cholangiocarcinoma. Merizes, again, I'm just going through rare things actually. Anyone know what Merizes is? No? Any idea? So that's when, if you might have a big stone in the gallbladder that's causing inflammation, or it's stuck in the neck of the gallbladder, and it's so big it's actually causing obstruction of the cystic duct and CVD. Okay. Again, just one of those rare things. Cholangitis, Charcot's triad. So that's someone who's got a fever, right upper quadrant pain, jaundice. Whiz through that. Again, you can have a look at this. This is just a way to try and segregate your differentials. Probably going to have to wrap up very quickly. Obviously, make this available. Apologies, I was very late. So keep questions in your jaundice. Alcohol, obviously. Are they fever? Are you thinking it's ascending cholangitis or something? Or your weight loss things, because it could be a cholangiocarcinoma. Is it actually obstructing and you're not secreting your bile and things, so you're not absorbing, you're not digesting your fat? Hepatitis, screen for those, and other autoimmune, because that's related to the PBC and PSC. I haven't got time for this. Skip through this. Okay. So again, any upper abdo pain. For gallstones, 5 Fs. So, anyone know the 5 Fs? Yeah. Fair. Third time. Yeah, so I think there was mumblings of them all. Baseline investigations, LFTs, clotting, amylase lipase, ultrasound, maybe MRCP. Ultimately they're going to need the gallbladder out as sort of proper management. Flip through diarrhoea. So main things for diarrhoea, ask about blood, mucus, have they had diverticular disease in the past, any pain with it. Antibiotic use, so C.Diff, which is what I was going to quickly flick over. C.Diff, we had C.Diff, C.Diff last year. They love it, it's a current issue, it's, you see it every day, or people are, not every day, sorry, but you see it in hospital quite regularly. From C.Diff, for OSCE and for written, just know how to treat it. Okay, so I'm pretty sure it's a 2-week course of metronidazole. Vancomycin if it's more severe or if that's not working. And the key risk factors are perforation. You can get toxic megacolon. So again, type that into Google if you're interested in pictures. Ileus, that's just bowel not moving essentially. They're the main complications from C.Diff. Right, let's just flip through a few slideshows for your practice. So we'll do this as we go along, just so it's a bit quicker. What's this?
Ascites.
Yeah. What would cause it? We kind of already said earlier on. How would you treat, not treat it, but how would you therapeutically reduce it? If it's causing them shortness of breath, desaturate, they're going to want to do something about it.
Abdominal.
Yeah, fantastic, good. And you can always introduce infection when you do paracentesis, okay? So SBP is a risk, okay? What do you think that is before I even ask the question? Yeah, it is esophagus, yeah. So what's the invest?
Varices.
Barrett's, yeah, okay, good. Didn't even have to ask the question. Yeah, something they love. What's the cell change in Barrett's? Squamous and tubular. Yeah, fantastic. That's the thing. Not a great image, but what investigation do you think that is? Is that what I've asked? Yeah.
Is that the apple core?
Fantastic. That's the apple core sign. These random things that they seem to like keep putting in the slideshow. Do, as you go through your revision, do look up odd stuff, random stuff on Google, because as common as they do in the slideshow, and they'll probably say, here's a picture of someone's vomited, what would you do? You'd write down some management. They do throw in like interesting diagrams. So this is rectal CA. Chest X-ray in an abdo lecture. What do you think? Yeah. What do we call that? What would we like? Pneumoperitoneum. Yeah. To try and sound a bit better. Good. 2 causes of that.
Perforation.
Apart from the rude ones. Perforation. Yeah. Any other causes? Perforate. It's perforation until proven otherwise. Okay.
Vigorous sex.
Second? Yeah, well, yeah, if you'd... yeah.
I've never heard that before.
Yeah, good.
Iatrogenic.
Exactly, that's what I'm looking for. Iatrogenic laparoscopy. I had one the other day. The diaphragm was up here. Some silly urologist had left air in after a laparoscopy. But I was scared to put it. So put this on. Okay, This is a very good one. This one here. Someone want to tell me what it is? Yeah. Obviously, you take it on clinical context as well. So the not passing is probably a bit there in the rectum. So ileopacic flatus. When was the last time you opened the bowel? Yeah. Why do you think it's large bowel?
You can see the house penetrate all the way across.
Yeah, location, these, look at the size as well, and you've got this one nice for comparison on the other side. So, if that's that, what do you think this is? Yeah, fantastic. I think I've asked for some causes actually. This is quite a good thing to know actually. Causes of, try to do 2 causes of large bowel, 2 causes of small bowel. Oh yeah, and how would you treat it as an F1? Not therapeutically treat it, but how would you treat it as an F1? You know, this person's vomiting up green liquid. Second? Drip and suck. Yeah. Do you know the type of NG you put down? Yeah. Fantastic. So causes can just be constipation. Remember hernias. That's important. Adhesions, as people have had loads of previous abdo surgery. More serious, tumours, but you can also get in Crohn's. Gallstone ileus, anyone know gallstone ileus? What is that? Go on, shout. Yeah, and then transfers down, ileocecal valve, gets stuck. Sigmoid volvulus, again, that's a good thing to know on your x-ray. Drip and suck, essentially, nil by mouth. Write them up for some fluids, okay? You're obstructed, you're going to be hypokalemic, put some potassium in the fluids, make sure they're getting the daily fluid requirement and they've just vomited up the load as well. Okay, last one. What investigation is this?
MRCP.
Yeah. A? Yeah, gallbladder with.
Stones.
Yeah. B?
Sphincter.
Yeah, I say distal.
Distal CV.
Yeah. What do you think you can see?
Stones.
Yeah. Not sure. On ultrasound, you might, MRCP report, you get how dilated this is causing. And obviously, on your LFTs, you want to see if bilirubin's increased. ALP will be, but you want to see if they're actually jaundice, essentially. C. Yeah, it's good. The pancreas is the pancreatic duct. And D. I think that's just the duodenum. That's the contrast. So yeah, what's the diagnosis?
CVD obstruction.
Yeah, so choledocolithiasis. So that just means it's in there. Clinically, who knows? They might have cholangitis. Got a fever, a jaundice. Could be cholecystitis concurrently as well. So again, on your scans and things, Murphy's positive on your exam and things. Okay, that's it. So I always do last couple, but it's late and go relax in your evening. Thank you for listening.